So there are conditions, initially we talk about that there are multiple options. Like you can go for alveolar resection, you can go for short segment resections, you can go for, like if there's a proctitis, then you have to go for proctectomy. So there are some definitive options you have available with you. So in case of the ileocecal resection, it means the disease, it entirely depends upon the extent of the disease. So if the disease is involving the ileum and if the disease involving the cecum, then you have to do the ileocecal resection. It's like you are resecting the terminal ileum and you're resecting the cecum, and then you, depending upon the extent of the disease, if it's involving the ascending colon or it's involving the transverse colon, you do the primary anastomosis, and the anastomosis, if there are no signs of sepsis, then you can do the primary anastomosis. Like this is the portion of the cecum, and this is the portion of the distal ileum which is attached to the cecum, and you resect whole of this portion, and you do the primary anastomosis with the proximal or the remaining part of the ileum with the ascending colon, or you do it with the transverse colon, depending upon the location of the disease. As already been discussed, especially the Crohn disease is a kind of a inflammatory process in which there are skip lesions. And if there are multiple skip lesions, then there are multiple skip lesions, and there is a chance if you do the continuous whole resection, then there is a possibility that most of the portion of the gut would be lost, and the patient will develop the short gut syndrome. So why this? You do a segmental resection. Either it's a large bowel or it's a small bowel. You do the segmental resection. For example, and suppose this was a mesentery and this was the diseased portion. This was the healthy portion and this was a diseased portion. So what you do is like you remove the diseased portion and you do the end-to-end anastomosis with a healthy portion. So you do wherever the skip lesion is present, you just remove the diseased part and you anastomose the primary part. Remove the diseased part, anastomose the healthy part. So that's how you do the short segmental resections, and that's just to avoid the complications like the short gut syndrome. And if there is a chance that a lot of area would be lost, so you do the segmental resections. So it's actually you can do it's like if you can see here, this is the diseased part and this is the healthy part, and you're reconstructing, you're just removing, you're resecting the diseased part, and you're doing a primary anastomosis. Either you do a single layer extramucosal end-to-end anastomosis, or you do a full through and through anastomosis in the form of the double layering. So that's how you do it. That's particularly, and then you have to check for the patency. This is like you have to hold the segment in your thumb and a finger, and then you have to palpate if there's a stricture or if there is any obstruction secondarily to the anastomosis. That's how you do the segmental resections, and that especially for the skip lesions which are involving a large portion of a small or a large intestine. Okay, so there's a possibility that ileum is not involved and only colon is involved, and there are ulcerations of the colon, and the patient is actually suffering from colitis, and then you have to do the colectomy, and then you have to anastomose the ileum with the rectum. And it's like a colectomy is a pancolectomy because most of the time ascending, transverse, then distant colon is involved, and you have to do the pancolectomy. Just like this. This is a portion of the small intestine, and this is a portion of the large intestine. So if the colon is involved and there are multiple skip lesions, that in a way that the segmental and short anastomosis and segmental resection is not possible, then you have to do the pancolectomy. And for that, and then you have to do the ileorectal anastomosis. And for that, like most of the part of the ascending transverse and the descending colon is resected, like it's a pancolectomy, and this is the portion of the ileum, and this is the portion of the rectum, and then you do the ileorectal anastomosis. So this is for the extensive disease which is involving the large bowel, like the patient is suffering from Crohn's colitis, and there are multiple skip lesions, and you cannot perform the segmental resections. Then the option is like you have to go for colectomy and ileorectal anastomosis. Another options for the Crohn's colitis is subtotal colectomy and ileostomy. It's like removing the diseased portion of the colon. It's not like pancolectomy or removing the whole of the colon, but you just have to remove the ascending colon, the transverse colon, the descending, and the sigmoid colon. So you do the resection till the descending colon, and a sigmoid colon is left, and then you do the ileosigmoid anastomosis, like just in a way, or you can do the colostomy for the time being, and then you can do the definitive repair, which is actually you do the colectomy, subtotal colectomy, and you do the ileostomy or colostomy. Most of the time ileostomy, and then either maybe possible in sometimes the patient have to be put on permanent ileostomy, just like that. So resect the most of the part of the colon, the ascending colon, the cecum ascending colon, and the transverse and the descending colon, and leaving the sigmoid colon behind. And then you do the subtotal colectomy and ileostomy, bringing the ileum in the form of a stoma, and then later on, after some time, you can do the anastomosis, which is the obviously the ileocolic anastomosis later on. But most commonly, it's like you perform the subtotal colectomy and you do the ileostomy, and then you do the definitive repair later on. Another is a temporary loop ileostomy. So it's like the same thing. You're bringing the ileum to the exteriorized. You just resect the segment, and you divide the ileum and separate it from the cecum, and you remove the rest of the colon. You do the colectomy, and you make a temporary loop ileostomy, and then later on you can do the anastomosis. So there's another this is the colon. Most of the colon and the rectum is being removed, and the ileum is brought out as an ileostomy. See, you can see here. And sometimes it's a temporary loop ileostomy, but if you do the rectum is also removed and proctodectomy is also done, then it's possible that the patient will end up in a permanent loop ileostomy. So ileostomy can be a double barrel or a single barrel. That's another topic for discussion. So in the extensive diseases in which there's a proctitis, and there are ulcerations of the anal canal, then you have to do the proctodectomy, or you have to do the proctocolectomy, just like that. This is the part which is being resected. The whole of the colon is being removed, and ileostomy is done, and then later on, you can do what you can do is, like, if there is a portion of the colon left, you can do the proctocolectomy. So the proctocolectomy with the J pouch reconstruction. So it's basically a stage 2 process. In the first stage, you remove the you do the proctodectomy, and you do the ileostomy, and later on you can perform a proctocolectomy, just like that. Okay, so now the topic comes of if there are strictures, how you gonna treat the stricture. So first thing we have discussed initially about the stricture is the endoscopic dilatation. But if there are large strictures and they're accompanied with the especially when they're accompanied with the acute inflammatory process, then obviously the option is like you can go for endoscopic dilatation, and then you have to perform the stricturoplasty. And in the stricturoplasty, what you do is like you identify the part where the stricture is present. You you made a vertical incision just along the whole length of the stricture, whatever possibly the length is present, and then you have to do the stricturoplasty, and then you have to repair it in a transverse process, just like that. If let's suppose there's a transverse incision made, there was a vertical incision made like that. And there are a couple of methods which can be used for structuroplasty, but the most common is a Malloquet's structuroplasty, in which a vertical incision is made along the whole length of the structure, and then after removing the structure, what you do is like you transversely, initially the vertical incision was made, and then you suture it in a in a transverse manner instead of vertical manner. So that was the incision, like this, but you close it in a way like this. So what will happen, that it will give a transfer diameter, and the luminal narrowing, which was because of the stricture, that would be dealt with the help of structuroplasty.